Oh, my mic was on. So your slides are going to show up here, but there's going to be a little bit of a delay, like a couple seconds, but they will show up. All right, folks, we're going to get started. Welcome. Thank you to everybody that is here in person and to everybody who is online. The camera's up on the wall, so if we're looking at that, here's why. Thank you all for joining us. My name is Chris Matthews, Chair of the Social Democratic Caucus. I guess I'm also here as Secretary of the Norwell DTC tonight because this is a joint event. I want to thank Kevin Jones, Chair of the Norwell Dems, for being here and putting this together. Very excited to have this presentation. So excited to introduce Dr. Alison Norris. Dr. Norris is a professor in Ohio State Colleges of Public Health and Medicine, Ohio State's Colleges of Health and Medicine. She's a co-principal investigator of the Ohio Policy Evaluation Network, an interdisciplinary research program that studies the impacts of reproductive health-related policies and laws on the health and well-being of Ohioans and people in the region. She also co-leads the research steering committees for We Count, a national abortion reporting project that measures the impacts in all U.S. states of Dobbs, the U.S. Supreme Court case that overturned Roe v. Wade. Dr. Norris has been engaged with sexual and reproductive health research in East Africa and the U.S. for 25 years with a goal to improve access to contraception and abortion, prevent unwanted pregnancy and sexually transmitted diseases, and reduce stigma about sexual and reproductive health topics. So without further ado, we're very excited for this presentation. Housekeeping, we will have time for Q&A. If you have a question, hold on to it until after the presentation. For those of you that are watching online, you can send us an email and we'll have the email on the screen with questions, or you can ask a question directly on our YouTube or Facebook stream and we'll be able to pop them up on the screen. So
thank you. Thank you. Thanks so much. It is really such a pleasure to be here. Thank you for inviting me. As I was preparing what I was going to share with you all today, I really enjoy the process of thinking about it because oftentimes I'm speaking to people who work in a very similar area that I work in. And so the opportunity to speak with people who work on so many other things and to think about the ways that our joint efforts connect was really, I'm going to enjoy this hour and I hope that you do too. As Chris said, I really will love to have a conversation. So make a note as I'm talking if there's something that you want to follow up. I would really enjoy that opportunity. As Chris said, I'm a faculty member at Ohio State University and I study abortion both in my region and in the US. I also grew up my whole life in Norwell and now I'm happy to be presenting to you today who raised me and were raised with me. And indeed, the Supreme Court's decision of Dobbs versus Jackson Women's Health Organization was issued in late June of 2022, overturning Roe versus Wade. And with that decision, for the first time in 50 years, each state's legislature can decide whether to allow abortion in that state. And so we're going to talk today about some of the consequences of that Supreme Court decision. And yes, this awesome tech. So as Chris mentioned, I co-lead the Ohio Policy Evaluation Network. Okay, good. This is my opening slide. Can I put it here? Down there. Okay. Maybe. Or spacebar, I'll try.
Oh, you know what? You are pausing YouTube, that's why. Sorry.
Oh, sorry.
So, over here.
I just need to have it off that corner.
There you go. I'll remove that. Are you able to move?
Oh, you said there's a delay. Maybe that's
so you should be able to. There you go.
Okay, so I see it here.
Yep.
All right. Okay, good. So OPEN is a collaborative research group, and in a moment, you can see a slide that has pictures of everybody on our very large team It is really a great fortune of mine that I work with a big, smart group of interdisciplinary scholars on a topic that is important to us. I'm going to set the stage here for us with several different frameworks. As I mentioned, Dobbs was decided in June of 2022. Immediately following that decision, 9 states banned abortion completely. By February of 2024, 14 states have banned abortion completely. And I will have a map coming up on the screen here that is color-coded with the dark red as the most restrictive and the dark blue as the most protective. There's a real heterogeneity of access to abortion in the United States. There always was. States had more and fewer restrictions in place pre-Dobbs, but the extremes have become much starker after Dobbs was decided. In states that ban abortion, the number of abortions provided per month in the entire state, states like Texas, drops below 10 per month, as exceptions are very rarely operationalized. In other states that have 6-week bans, Georgia and South Carolina, their numbers drop by 50%. Clinics and patients and abortion funds push very hard to get patients in just a few weeks after they learn that they're pregnant. But of course, many patients don't know they're pregnant and are unable to obtain care before 6 weeks. In states that permit abortion, we have seen the numbers go up. And in fact, they've risen so much that the total number of abortions in the US is greater now than it was pre-Dobbs. So we really are seeing a picture of a public health triumph. This is what happens when services are expanded and barriers are reduced, and a public health crisis when people in 14 states can't get health care in the places where they live. I'm going to pivot now and talk just a little bit about who has an abortion in the United States, who needs an abortion, who gets an abortion, and what happens when people don't get the abortions that they want. Americans have a very wide range of feelings about abortion. Many of them are very complex. Abortion is highly stigmatized, highly politicized, very common, and very safe. 1 in 5 American women will have an abortion in their lifetimes. Abortion is safer than colonoscopy. More than 900,000 people have an abortion each year in the United States. So maybe some of these data that I've just provided are surprising to you. Even though abortion is so very common, it's not something that we talk a lot about. And so its commonness and its safeness can be just a piece of information that is missing from our conversation. And people with all types of belief have abortions. Conservative women, transgender people, young women. None are immune to contraceptive failure or illness to the fetus or to the pregnant person or to experiencing rape. Many people find that no matter what their beliefs, carrying a pregnancy to term is not something they can go through with, and so they have an abortion. There's a concept I want to share with you called reproductive justice. It was described by a group of Black feminist scholars in 1994. And it is the human right to maintain personal bodily autonomy, to have children, to not have children, and to parent the children we have in safe and sustainable communities. This concept of reproductive justice underpins what motivates me to do this work. And the other thing that underpins my motivation to do this research is the public health implications of having an abortion if you need one, and being denied an abortion. And so I'm going to talk to you a little bit about a research project called the Turnaway Study. It was a study of 1,000 people, 1,000 women, 500 of whom obtained an abortion, and 500 of whom were just on the other side of a gestational limit at the clinic or in the state where they were obtaining abortion care. So it's for the first time the Turnaway Study was able to say what happens to a group of people who get an abortion when they need one and what happens when they don't. And it's a really amazing piece of scholarship, and it's a very good book called The Turnaway Study. And Diana Green Foster, who did the work, won the MacArthur Genius Award last year. what these, among the many things that the study found, is that people who don't get an abortion when they need one are more likely to be living in poverty years later. They're more likely to remain living with a violent partner. And the children that they have are meeting developmental milestones, as are the children of women who have abortions when they need them. Giving birth is 13 times more likely to result in a death than is abortion. So my research is guided both by the public health science about the benefits experienced by people who are able to obtain abortion if they want one, and by the justice orientation that it is a human right to maintain bodily autonomy and to not have children. And I'll just remind us to keep in the back of our mind that reproductive justice goes far beyond access to abortion, although this is my focus today. I'm sorry, I'm like a little slow on these slides. Eventually, findings from the churn study will pop up. I'm going to pivot to talking about US numbers of abortions. And I have a little bit of data to show you, but I'll describe it as well. About 45% of pregnancies in the United States are unintended or mistimed. So almost half of all pregnancies in the United States are the person wasn't trying to get pregnant at that time. About a third of those unintended or mistimed pregnancies end in an abortion, which, as I mentioned, amounts to about 900,000 per year. Those people who are the most disadvantaged in accessing healthcare and other social goods, including people with fewer financial resources, younger people, people who experience racism and sexism, not surprisingly, are more likely to have an unintended pregnancy and are more likely to need to access an abortion. So when we talk about barriers to access to abortion care, we're talking about barriers that are experienced similarly for other kinds of healthcare. Difficulties getting time off of work, away from childcare, responsibilities, the costs of that care, the logistics of travel. And these barriers are more difficult to overcome for people who face more disadvantages. So really there's a double jeopardy. People who are most likely to need the care are the same people most likely to find the barriers to that healthcare insurmountable. In contrast, people with more resources are both less likely to need an abortion and more able to get one should it be needed. As I'm presenting today, I want you to keep the center of your attention not necessarily on your own current experience. If you're a person who's been privileged with resources of money and the ability to control your working hours and access to information in your own car, but instead spend your thinking on the person that you used to be, or people you know who have the least resources. They are no less deserving of access to care, but access may be out of reach. This next one that will pop up is an image showing the distribution of US pregnancies from some data that are a little bit older, about 5 years older, 10 years older, that about half of pregnancies are in that yellow, in the orange and the gray, and that about 16% of abortions in the United States, pregnancies in the United States end in abortion. Now, my next slide shows abortion type and gestation in the United States, again, just to kind of put us all in the same conversation. Medication abortion is represented here in blue, and abortion by medication is very common in the United States. In fact, getting more and more and more common. Sometimes medications are accessed in person at a clinic, and sometimes they are accessed via telehealth without an in-person visit. And this kind of data has been shown to be just as safe as in-person care. Medication abortion can only be used up until 10 or 12 weeks of pregnancy. So you can see in this slide, the reddish stripy bars are procedural abortion. There's a shift away from calling it surgical abortion, which is what it was called for a long time, because it isn't a surgery where there's anything cut or sewed together. And so procedure is a more appropriate description. And you can see that the vast majority of abortions happen early in pregnancy, before 9 weeks, and then the numbers drop really starkly after that. Most people will obtain an abortion as soon as they can after deciding that that's what they want. Abortion earlier in pregnancy is technically easier, it's faster, it's less expensive, it's less likely to have complications. People also have abortions later in pregnancy for a wide range of reasons. Those abortions are just as needed. And any gestational ban puts care out of reach for some. Massachusetts has quite a liberal gestational ban. It's 24 weeks, which is later in pregnancy than other states. But the argument that underlies my statement that gestational bans put care out of reach for some is someone who needs an abortion who's just after that time limit is now facing an arbitrary line that doesn't really have something to do with their individual case and their health and the situation that they find themselves in. Okay, I'm going to talk a little bit about barriers to abortion care. So some of the key barriers are being able to get to a clinic. People without a clinic nearby or without public transportation require a car, which is a huge barrier for many thousands and millions of people. Being able to pay is a big barrier. In Massachusetts, there's a lot of progressive action in this space. So Massachusetts is one of the few states, one of about 30 states, where the state provides funding for people who need abortion who have Medicaid as their insurance. State where I live in Ohio, that's not the case. So people who are poorer use Medicaid as their insurance. And once again, it's another barrier that's higher for people who have less. Okay, then I'm going to give you a little bit like an overview of the legal landscape in Massachusetts. Some of these I've already mentioned. Abortion is banned at 24 weeks and later. State Medicaid funds cover abortion. Private health insurance plans are required to cover abortion in Massachusetts. People who aren't MDs can provide abortions. State funds help patients pay for abortion care. So these all sound like pretty ordinary things. Like these are things that are available for many, many types of healthcare. But in the state where I live, in Ohio, all of these things are not true. We have a ban at 22 weeks. For a time, we had a ban at 6 weeks. State Medicaid funds do not cover abortion. In fact, my own health insurance does not cover abortion. I work for the state through Ohio State University. And only MDs can provide abortion care. Definitely state funds do not pay for abortion care in Ohio. Your state goes further, providing protections from harassment and physical harm for anyone entering an abortion clinic. And then this shield law is a new thing. These shield laws came in 5 states in July of 2023. Now California has just added a shield law, so there are 6 states. It protects providers in the state from investigations from other states if they provide telehealth care to someone who lives in a state where there's an abortion ban. It's an important innovation that's changing the landscape very rapidly. And then also, there had been a ban in Massachusetts for a long time that people had to be 18 years old to seek care by themselves, and now 16 and 17-year-olds can obtain care. There are also barriers to care in Massachusetts. Many of them are geographic. There are no providers of routine abortion services on Cape Cod, Martha's Vineyard, Plymouth County, New Bedford, Fall River. Provision is even more hard to come by in Western Massachusetts. This is true in a lot of states that in more rural parts of the state. There just are fewer healthcare providers of any type, and abortion providers oftentimes none. And so people who live in rural parts of the state have to travel a lot further. I've already mentioned this, but discrimination, this is true not especially of Massachusetts, but definitely true also in Massachusetts, that the things that keep people from accessing reproductive health care more generally are present, and those barriers are increased for abortion because of the stigma that surrounds it. In Massachusetts, Black women are almost twice as likely to die during pregnancy or within 1 year postpartum compared to white women. And so if people are unable to obtain an abortion, they are, Black women in particular, are in a much more dangerous situation. I want to share briefly a concept that's somewhat more subtle, abortion care churn. This is something that happens at the state or clinic level where the instability of abortion care services and chronic uncertainty about potential closures or changes in services have real impacts on the people who live in the state. It isn't, actually, I will investigate, but I don't know now how much of this is experienced here in a state where there are more states legislative protections for abortion providers. In states where there is a lot of legislation, there can be at the clinic level an instability about what services are going to be permitted to be offered, what gestation facilities will be permitted to go to. There can be new barriers put on the clinics that force prices to change, and the amount of financial aid that's available for patients can be dynamic. So in states with many regulations in place, these are fluctuations that result in changes in service delivery, and they impact the public's perception of the clinic status, which kind of all adds up. Both the reality of the changes and the perception of the uncertainty adds up to being another barrier for care. Okay, I just today got some new data from my research group, but I'm going to skip over it and we're going to come back if we have time, because it's really juicy, but it takes a little time to explain. Okay, so I want to pivot now to talking about national and state level changes following Dobbs. And these are data that come from a project that I co-lead the research steering committee. It's called the We Count Project. And we started collecting data 2 months before the Dobbs decision, and now are still collecting data monthly up until now. And we collect data from 80% of all abortion providers in the whole United States provide data to our group. And then we have, I'm an epidemiologist, and we use estimations to account for those clinics that don't share their data. So what I'm showing you are the estimates of the total numbers for the whole country. Each clinic reports the number of abortions that they provide each month from April of 2022 through these data are through July of 2023. And we provide the findings summarized at the state level. We have a new set of data that are being released on Wednesday. So I kind of thought I might get it out a little bit early. So I have some data to show you that are from July. And then if you're interested in it, it'll be in the New York Times on Wednesday. So this first picture shows shows the total number of abortions in the United States by month, and it marked the Dobbs ruling here. So this is on an auto timer. So that dotted line shows you what the number would have been had there been no changes from the Dobbs decision. And what's the big takeaway here is that the number of abortions in the United States did not really go down. There is a dip in the summer that's typical, actually, or it's actually in the autumn. There tends to be a seasonality to the use of abortion care. And so these numbers, despite the fact that 14 states lost abortion care completely, the national picture shows that people are still getting abortions. And then I'm going to pivot to you and show you, the automations don't look so hot. Sorry about that. But okay, so now I'm going to show you abortions across the US states in the states that had total abortion bans. And so the months pre-Dobbs are shown on the left, and then the precipitous decline down to zero in the states that had the abortion bans. And once again, I've got the black line showing you what it would have looked like in those 14 states. It's about 8,000 abortions per month would have been provided had the Dobbs decision been decided differently in states not permitted to ban abortion. Okay, and then I have a final slide that breaks down all these individual 14 states to show it's a symbol. This is a cumulative picture here, and then the next slide shows them by individual state. And Texas is the brown, the one that provided the most abortions pre-Dobbs. And actually, this is a 50% reduction because they had a 6-week ban in place for about a year before the Dobbs decision. So there's a dramatic loss of access in these 14 states. Cumulatively, there have been about 94,000 fewer clinician-provided abortions in the year following Dobbs. And these numbers are not able to tell the individual stories of people seeking care, but they make visible the size of the impact of these restrictive laws on abortion access. So what happened to these people in these states? Some of them likely traveled and obtained abortion care in another state. We do see big increases, especially in states that are adjacent to states with bans. And indeed, in states where abortion was permitted, we see increases of thousands. And it seems in part that a meaningful proportion of the increases are due to improved access by people in the states where abortion was permitted. So Illinois is a good example. Illinois is in the Midwest, and it serves a lot of people from the Midwest and the South where states had banned abortion. And a meaningful fraction, Illinois had a huge increase, and a meaningful part of that is people who were able to access abortion who lived in Illinois, who perhaps wouldn't have been able to access it before, due to the influx of money and information and increased number of providers. So what happens if you can't get an abortion in your state? Many people who know they are pregnant in time can use medication abortion, and not everyone prefers to use pills, and many people will be later in pregnancy. I'm going to skip over some of this about abortion travel, and I want to dive in a little bit into Massachusetts. So I have an image coming up that shows that the line across the top showing the national picture, and then at the bottom, not to make you all feel, we'll have a little moment of humility, because this is Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island. They're relatively small states compared to some of the huge states and huge abortion providing states of California and New Jersey and New York. And so they don't contribute so much to the national picture. So let me dial it out a little bit, and we'll look just at Massachusetts. But now the scale has changed. And the Massachusetts line runs between the 1,500 and the 2,000 line. That's the monthly number of abortions provided in the state of Massachusetts. Massachusetts is one of 6 states that has a shield law. And I'll show you a little bit of data about how telehealth abortion is being provided through the use of shield laws, and tell a story about a provider in Massachusetts that's playing an important role in that. So when I think about abortion care in America and sort of the two Americas, right? This public health triumph and the public health crisis. And Massachusetts is a place where the triumph is happening. Health expansions are being put into place, including access to reproductive health, including abortion and resources for families. And then there's the America like we have in Alabama and Texas and Indiana, where public health resources for preventing pregnancy, for terminating pregnancy, and for caring for pregnancy have been slashed. And then I think also that within every state and every county, there are still those two phenomena at play. So here in Massachusetts, there are people who are able to access abortion care. There are providers, there's funding for aid that isn't covered by insurance, there's more legal protections. So people in Massachusetts shouldn't be as uncertain about whether abortion is available and legal in their state. But there's still a second Massachusetts. There's people who can't get a day off work on a schedule or can't get childcare that they need, and so would have to rely on an abortion fund that they might not know exists. And there's the massive power of stigma against abortion care that contributes to a real information desert for people who aren't inside this bubble of healthcare access and political know-how that we live in. So I posit that the role that you all can play is in closing the gap between those two Massachusetts. One way that you can do this is through how you talk about abortion, to destigmatize it a bit. When abortion is destigmatized, people are able to learn about it. They can know what their options are earlier in pregnancy. In general, there become more social resources available to people who need care, and social and financial resources. And there's more political will to make sure that Massachusetts continues to be on the leading edge of protecting access to abortion. I heard this interesting thing recently. An abortion provider said that nobody ever comes in and says, I would like reproductive freedom, or I would like choice. They say, I would like an abortion. And so that's one way that we can all do the work of destigmatizing. It's just to let the word be part of our conversations without qualification. And so many people in America have abortions, 1 in 5 women in their lifetime. And when we talk about abortion, it's easily connected to other things that each of us cares very deeply about. There are those of us who care about access to work and dignity at work. And of course, people who have a forced birth have a lot more challenges around work than people who don't. Food justice, environmental justice, plain old democracy. These are all very tied up tightly with reproductive justice. Because if we go back to the tenets of reproductive justice, it's the human right to have a child, to not have a child, and to parent the children we have in safe, sustainable communities. I'm going to just tell you a little bit about telehealth abortion because it is it's a way of delivering medication abortion care, and it's transforming the national picture. There was an article in the New York Times last week that was describing abortion provided under SHIELD laws. Nationally, there are 3 main providers. They're called Lead Access, the Massachusetts Medication Abortion Access Project, called MAP, and a service called Dobbs. These services charge $150 to $250, which is much cheaper than an in-person clinic appointment. And they also all provide at reduced prices based on what patients say they can pay. And so Angel Foster, who's the director of the MAP, was quoted in this article saying that about 1/3 of the patients pay only the $5 minimum that the service provides for people who say they can't pay. This next slide is from the We Count study, and it's showing month by month the number of telehealth abortions in the country. The trend is steadily moving upward. As of June of 2023, about 8% of abortions in the US were provided through telehealth. So that's through either virtual-only clinics, because as you may remember, I said these SHIELD laws started in July. So these data are not providing abortions in states where there's abortion bans. These are only virtual clinics that are doing telehealth medicine in states where abortion is permitted. We have the next 3 months of data, and the number goes way up because now we're able to include all the abortions that are provided under SHIELD laws. And your own homegrown map is an important part of that story. So I think there are several things you can do to support abortion access. You can be an abortion destigmatizer. And I've already talked about some ways to do that. No, I had the opportunity to reflect today how abortion is like a very often for many people a private thing that they do. It's something that's part of their healthcare. It's part of their life course, and it is something that is private to them. And that's not inappropriate. It's like many kinds of healthcare. We don't tell everybody about. We experience them with our intimates. And at the same time, if we don't talk about some particular kind of healthcare, it then can be caught up in political eddies that have nothing to do with the actual healthcare, but do, I mean, in their design, except in their function, they do end up impacting people's ability to access care. So I would just welcome you to find opportunities to talk about abortion in an easy way. Also, I'd urge you to care about your local and state elections and laws. States like Massachusetts are really making the template for what states across the country do, and each step that goes further makes it more okay for other states that are behind to take those next steps. And in my own state, we have more than 24 abortion restrictions, including a 6-week ban that was in place for 3 months right after Dobbs. And then we have a statewide referendum. Activists in the state brought forth a state amendment to protect reproductive freedom, and it passed resoundingly. So when we bring these things to be a truly democratic vote, we see a very different picture from what we see in a gerrymandered legislative environment. And then the final thing that is available to you is to share your own financial resources with providers and with abortion funds. I am putting up on the slide here, in case this is of interest to you. The map I've talked about a couple times supports provision of medication abortion to any person in the United States who requests the service. And also the National Network of Abortion Funds is a national organization that supports 100 different independent abortion funds across the country. And what those abortion funds do is they support people both paying for abortion and all the things, the financial and logistical challenges that accompany needing to travel for care. I think that I will stop there. I would really love to hear what you all want to talk about. And thanks again so very much for inviting me to be part of your conversation today. Yes. Oh, great. Thank you. And will you say your name? Oh, thank you.
My name is Mandy Metzger, and I wondered what your thoughts are on what I feel is a bit of a media silence. I know there are some very well-known cases, but so few. The friends I know in Texas and Ohio are silently talking about ruptured membranes at 20 weeks and fevers in parking lots. And I don't know if it's the people they work for who's sort of hush, the hospitals in charge who don't want these stories out, or is it just the media suppressing it? I just would think there's a lot more happening than what we're hearing about.
Yeah, thank you, Mandy. You raised such a good question. This has been in some ways part, I think, of the national conversation, which is if you ban one kind of reproductive health care, it's going to have fold out consequences on all kinds of other reproductive health care. So if someone's having a miscarriage later in pregnancy and there's a sort of medical inevitability of it, but there's still a heartbeat that healthcare providers will be afraid to do that miscarriage management because they're not foolish to be afraid. There are felony penalties associated with being found in violation of the laws of the state. So there are a couple different pieces of work that I know are happening. One is there's a study in, well, the researchers are based in California, but basically they are asking healthcare providers to share their stories, either anonymously or with attribution, so that they can have not just, fortunately, these things are kind of rare. That's maybe an important piece of it. Any one healthcare provider isn't seeing that on the daily. And so it needs to be a collective effort in order to see the impact. And so these folks at UCSF are collecting those data, and they've begun to publish them, but it's moving slowly. And then I think you're right, there is some work in the media about the follow-on effects, like healthcare providers deciding to leave a state because they don't want to be in a state where they're at risk of either not providing the care they're trained to provide or be accused of a felony. And so when the well-trained maternal fetal medicine specialists leave the state, all the people who relied on them for the whole range of services they provide are bereft of that care. And I think a piece of the tragedy is that it's hard to draw the line backwards exactly. Like if you could lay at the legislators' feet, you passed this law and these 3 women died in childbirth, it would be more like compellingly terrible. But of course, things are so multimodal, and any one outcome is not driven by a single effect. And so that's part of that destigmatizing, right? That even abortion care, even people in medicine don't really like to talk about abortion, some of them. And it is this, I think there will be a slow turning of the tide as it becomes clear what's in the dragnet when you ban one kind of healthcare. What are the follow-on consequences from that? But it takes some time. Thanks, good question.
So we're going to get some questions online. I'm going to pop up on the screen in a second. But Colin has not been called, having been an advocate for abortion rights in the 1970s, having a movement to destigmatize abortion as a healthcare right.
I love that question. One thing I wanted just to think a little bit about with you all is why abortion stigma is so pervasive. And I will offer 5 ideas. One is that our society has an ideal for womanhood that involves being a mother and being a nurturing person. Although the majority of people who have abortions are mothers already. And of course, being a nurturing person has really nothing to do with having a uterus or the contents of your uterus. Choosing an abortion is seen on some very deep societal level to be in conflict with those ideals of motherhood. So it is possible that those of us in this room can both feel very strongly that people should have access to abortion and hold some of those ideals in our own hearts. And so living a little bit with that tension, I think is important to understand that piece of stigma. Attributing personhood to the fetus is another part of what stigmatizes abortion. Of course, we're seeing a big case play out there around embryos and in vitro fertilization, which is sort of bringing this question to the fore for a lot of people. Legal restrictions themselves reinforce stigma, like if something's against the law, it must be because it's bad. The idea that abortion is dangerous or unhealthy, this comes from a time when abortion was unsafe in the United States and in other parts of the world where it's illegal. Abortion is very safe when it's practiced in a healthcare setting. And then stigma is used as a tool by anti-abortion activists. So I think understanding those pieces helps a little bit to identify for ourselves how we can, when we hear pieces of those stigma being lifted up, we can have a way to counteract that. And then I also just want to speak for a minute about good abortions and bad abortions. This is a subtle way that people unintentionally stigmatize abortions. In the public discourse and from the perspective of people having abortions, there is this idea of good and bad reasons for having an abortion. And so good abortions, I'm saying quotes, are those that are judged to be more socially acceptable Maybe they evolved a fetus with major malformations, a pregnancy that occurred despite a reliable form of contraception, a first-time abortion, an abortion in the case of rape, a very young woman, or a contrite woman in a monogamous relationship. And bad abortions, in contrast, occurred later gestational abortions are had by selfish women who have had multiple previous abortions without using contraception. And so for the sake of destigmatizing, it's important to observe those in ourselves and let them go. When people need an abortion, they need an abortion, no matter the path that brought them there. So thanks very much, Paula. I would like to know whether you have also thoughts about how to move ahead in destigmatizing. Okay. I will share with you one cool bit of data that I got today from my research group. So we have a study that surveys, it's a state population representative sample in Ohio of reproductive age women. And we have a baseline data collected in 2018, 2019, and then we have an inline survey. We just got the data collected in 2022 and 2023. And in the baseline in 2018, 40% of people who took part in the survey, okay, they're different groups of people. They're both drawn from the same underlying sample, but it's not like we have the same people at the two time points. But the people in 2018, 40% of them identified as pro-choice. In the data we got from last year, 59% of people identified as pro-choice. So I think that's also part of what's destigmatizing, is that there's like a moment where people get mad about something and they step from being a bit indifferent to being activated. And of course, we've seen that in social movements across our history. Some recent ones include marriage equality, the Me Too movement, the racial reckoning. Like, these are moments when people have kind of ignored something that they didn't want to engage with. And then something happens and a whole bunch of people engage it all at once. And so I think that's also part of the destigmatizing moment. Should I be looking for questions on here, Chris? Okay. Yeah, great. Does the map keep referral lists for mental health care providers in each state so that women can seek appropriate and supported mental health care in relation to their pregnancy and abortion experience? So this is a great question. And what I know a lot of these organizations do is they're very well networked. So, for example, the telehealth abortion providers, there's a heterogeneity of them. Some of them provide really amazing patient-centered care. I know the director of the MAP, and I think it's a correct assumption that they provide really thoughtful patient-centered care. Some of them probably are not as strong in that space. And so they rely on the other networks that exist. All of these groups are like interdigitated, like NNAP, which I showed the QR code for, that national network of abortion funds. They are networked so that people can get financial resources. And then there is a group called If, When, and How, which provides legal resources for people. And all of these are national, because they came up at this time that we live in and during COVID, a lot of the resources online are much better than they were in the past. And so there's another group, its name I'm not going to come up with now, because there is many people, for many people, the main experience after having an abortion is relief. But of course, there's a huge range of emotional experiences that people have, and a huge range of resources that they need. And so, might come to there. There's one very well-known group that's a resource for people who have had abortions in the sort of social support space afterwards. So I don't know that each group, they stay a little bit in their own spaces in a useful way. They stay in their own lanes and do the thing that they're expert at and send patients for more resources in the other spaces. So another question comes. Oh, good. Okay, good. Mental health cares are great for women in states where abortion is illegal. There's a ton of misinformation, especially in states where abortion is illegal. Okay, I'm going to take a minute to show you. Can I have my slides? I'm going to show you that. You see the data. So we asked. It's the same survey. So I've already now explained the data. So we asked in the baseline survey. We asked, "Is abortion legal?" Chris, it's the slide that has the blue bars, just blue bars. Yep. We said, is abortion legal in the state? And we were shocked that 10% of people in Ohio thought that abortion was illegal, because it definitely was legal. It was not illegal. It was legal. So this was a shocking, oopsie. Oh yeah, there you go. So this is a shocking piece of data to us. And we published on it, and also that 26% of people didn't know. Okay, that was in 2018. Over the next, we had 6 or 10 more restrictive abortion laws that were proposed. Some were enacted, some were then, the courts made a decision that they were unconstitutional, they were enjoined. I mean, it was a very turbulent time. We had restrictions about certain methods of abortion that could be used. Reasons why you could have an abortion. Some clinics closed temporarily because they didn't have access, they didn't have the correct relationship with a hospital nearby that was regulated in a very complicated way. And so then we asked this question again in 2022 and 2023. And if you can do the next slide. Now, 40% of a random sample of women in Ohio said yes, said no, abortion is not legal in Ohio. It's been legal the whole time. So this is sort of getting to that question about like mental health care. It isn't so much like that all these 40% of people need mental health care, but imagine that any one of them could become pregnant and think that they live in a state where abortion. And this is at the same time that all this political activity was happening about having a constitutional amendment to protect abortion. So I guess I'm just saying that information flooding into the system, that we needed this constitutional amendment could have contributed to people thinking maybe abortion's not legal, and that's why we need to have this constitutional protection. So when there is when a service is banned, or when the potential of it being banned looms in people's minds, it's very hard to understand if you are a patient who needs a kind of care, not thinking about your use of abortion on a day by day. Think about when you need it, which is maybe only one time ever. And so there's a ton of misinformation that floats around and contributes to the stress and the distress that patients experience. One of the things that we heard from abortion care providers in states that had surges, states like Illinois and Florida, where patients traveled from their home state in order to get care in a state where abortion was still available. The patients were showing up later in pregnancy, really distressed. It's hard to get a health care anyway. Something you need on a tight timeline that costs a lot more than you thought it was going to cost. It comes unexpectedly. All those things are distressing. To then get in your car and drive 100 miles or 1,000 miles, people were showing up really quite traumatized as they were arriving. So the stress on the healthcare providers in the states where people were traveling to was also high. There was a lot of stress in the whole environment, which then has consequences for the people who live in that state who are obtaining care, because the whole environment is now more stressed and more distressed. Please.
Okay, so back to the conversation about this DC
Patrice, would you mind going to Mike? Sorry.
All right, so I'm going to lump the two questions I got together, but it's basically the same topic.
Okay, great.
Right, so one question I have, and this is about how we talk about it politically. So one question is about men. Do you think we're actually seeing enough men, enough dads talking about what it means to them, for their families or potential wives or whatever? And have you done any research? Can you tell us, and maybe there was stuff out there already, about differences in the way those men, especially the dads, think about it that might be different from the way women, mothers think about it? And then the second part of it is something that just worries me, and it this conversation about the late-term abortions, that people who are against abortion seem to want to, say that all liberals think you can basically kill the baby, as it's dropping out. So can you talk about those two things?
Yes, those are such important things. So could men talk about abortion more? Definitely, yes. I kind of think the more we all talk about it, the less of a big deal it becomes in an important way. I do think a little bit of this kind of awakening, this people feeling angry and having a political awakening as a result. I do think it's happening also with men because, of course, men also profoundly benefit from people being able to access abortion. I mean, there's just no question. And yet it has oftentimes remained quite silent. So I really appreciate you asking that question. In my own little nucleus of my own little small community of my intimates, I have watched a transformation in men. My partner, my sister's partner, saying, you know what, we really should actually be on the front lines of these marches. It's our issue too. I think men do feel differently about abortion than women do. It's simply the difference of whether it could be your lived experience or it could not be your lived experience, right? We can feel sympathy for people who experience something that we can't experience, but we can't quite have that same visceral. For me, when I was pregnant and having a child, I became more convinced that nobody should ever go through this who didn't want to. Much more bodily. I felt it in my body, literally, in a new way. And so I think many women have access to that experience of having had a baby that wouldn't have access to that. Just tell me one word so I remember the other question. Oh yeah. So abortion later in pregnancy, that's one way that you can, that's language that's a little bit less stigmatizing. So that's the language that I use, abortion later in pregnancy. And I think it is harder because abortion later in pregnancy is different. For those of you who are in clinical spaces, abortion early in pregnancy is a very mild clinical experience. There's not really the products of conception are sort of really not much to see, and the procedure is very quick and the recovery is very quick. It's a very, I guess mild is the word that comes to my mind. And abortion later in pregnancy has more emotion attached to it because of business development. And so I do think it's appropriate to kind of treat the topic with some seriousness, but part of that seriousness is to say that it is undertaken carefully, thoughtfully, with extremely well-trained healthcare providers. It is healthcare that, when it's needed, it's an extremely intimate, personal decision that is extremely important to the person who's having the care, and to treat it otherwise as kind of a radical notion that that it's something that it isn't. It's takes away the dignity of the person who's having their pregnancy. So I think centering on the dignity of the person who's having the abortion is sort of the place where I tend to go to, that person deserves our respect and our attention and our care, and the access to health care that they need. Listen, this was really such a treat for me. Thank you all for engaging in this conversation.
So Alison, we wanted to thank you for coming. For those of you who don't know, Alison changed her flight to go home just to do this for us. And so we got you a little goodie bag for your flight home tomorrow.
Thank you.
And then this mug is for you to bring to work
Oh,
and display it with pride.
thank you, thank you,
Thank you.
thank you.
And thank you to your wonderful parents, Bob and Peg Norris, who were in the back. The former, well, still reigning Norwell Citizens of the Year for 2022. And then just to bring it all home, Norwell State Representative David DeCoste voted against the SHIELD law. And we're having this discussion because Donald Trump became president. And he may become president again. So let's get to work. Thank you so much.
So thank you everybody for joining us. Thank you so much, Dr. Norris. I wanted to recognize some of the folks who are in the room that I forgot to recognize at the beginning. Our DTC chairs, we have Kevin Jones from the Norwell DTC, Michael Grafton, chair of the Weymouth DTC. We have John Bowes, chair of the Marshfield DTC, Patrice Metro, chair of the Situate DTC, and Sue Renee, Pembroke DTC. We also have my colleague Karen Tellis from the Democratic State Committee. And then from the Norwell DTC, we also have Natalia Davis and Mandy Metzger with us, in addition to Bob and Peg Norris. So thank you all for joining us. March 5th is primary day. Please get out. Please vote for Joe Biden. If you're in our district, please check out my name. I'm unopposed, but would appreciate your vote. John Bowes, do we have any upcoming events that you want to announce at the microphone? And then John Bowes will close us out, and then we'll be done. Thank you to everybody that joined online. We had 34 people max online at one point, so very grateful everybody that joined us.
John Bowes, chair of the Marshfield Democratic Town Committee, and also a state committee person with Karen and Chris. Wednesday night, we have a forum on race in America. Norwell Democratic Town Committee once again, and Unitarian Church are co-sponsoring that. Friday night. Oh, I'm sorry. Where is it? First Parish, Unitarian Church, River Street, pancakes, awesome. And a great speaker. Please look online for that. And then very important, Friday night, Josh Cutler has taken a job in the administration. And we have a great candidate running for his seat. This is a seat we can lose. So we need as much help as we can get. Friday night, we're going to have a postcard party in Hanover. And we're going to be inviting people to Becky Collato's kickoff in Marshfield. So if you are available Friday night, 6 to 8 in Hanover, that's right next to the Market Basket. And then a bunch of us have caucuses on Saturday. So welcome to the Democratic Party. Tuesday is election day. Early vote is going on right now. Please, nobody knows this election's going on. Remind everyone in your network, you need to vote.